I want to welcome you all. These webinars have been very rich for all of us. And today I just want to take a little time to speak about Active Surveillance Patients International. The common thread that we see amongst active surveillance patients is a sense of anxiety when they're first diagnosed. And we realize that that anxiety, that worry serves no purpose. And part of our mission is to help you to progress beyond that anxiety and replace it with vigilance. The prostate cancer arena is much, much different from how it was 16 years ago when I was first diagnosed. Today, there's a lot of alternatives. You have a clearer end game. Our board members here on active surveillance are a unique blend of vigilant patients. And the interesting thing is that two of us have progressed gracefully beyond active surveillance. One you met already, that's Joe. Another is Throne, an Icelandic board member. And they've done this with vigilance and research. They were years on active surveillance, and then they just moved beyond it. And so the transition between active surveillance and treatment is much clearer, and there are so many safe alternatives. 40% of you on this call will probably progress beyond active surveillance. And so we know that that can be done without fear. And in my own case, I progressed the other way. And in fact, I just had the micro-ultrasound, which is the topic of this webinar. And when I had my micro-ultrasound, they could not find any cancer remaining, which was great news for me, obviously. So we have both ends. We have the people that are moving gracefully beyond active surveillance, and we have me that's moving to whatever I'm going to be moving to. I mean, I'm obviously going to be surveilling, but I'm probably just going to be doing PSAs a couple times a year. One of the things that's too unique about Active Surveillance Patients International is that we have a passion for knowing and studying the latest modality. So that's why Joe and I went out and got the micro-ultrasound. I could have gotten an MRI. I wanted to get a micro-ultrasound so I could learn about that technology, and we can share it with you. Joe also, by the way, just had the mpMRI, which is another leading edge technology. I don't know that we'll have time to talk about that today, but we'll see where this webinar takes us. So I guess our message to those of you that are feeling anxious, our goal is to shift your state of mind from one of anxiety to peaceful vigilance. Take a breath. There's no need for undue anxiety. There's no need for undue worry. The landscape has been laid out here. So today, just be present with us. And I think there'll be a lot to learn, but be confident that if you're vigilant, you're going to be just fine. I want to take a moment to thank Dr. Andreoli and Brian Woodlinger. These folks dedicate their time to you. We don't pay them. We can't afford to pay them. They're here for you. We're all volunteers. And by the way, Jeff, are you here or not? Jeff was going to say a word, but let me just say we rely on all of you to have the funds to move forward. So that's the pitch for keeping us alive. So I want to thank Howard too for his role in creating this particular webinar and others. And I want to introduce Howard. You are on now, Howard.
Hey, I'm Howard Walensky, one of the founders of ASPI. I'm glad you all can be here today on what is a holiday weekend here in the US anyway. I'll introduce the individual speakers as their turns come. Please use the chat box to ask any questions you can be asking now. we'll have a question and answer session after the speakers. Any rate, back in 2018, I first heard about a new technology known as micro-ultrasound. I was attending the Prostate Cancer Research Institute meeting in Los Angeles, and it sounded like a possible alternative to biopsies. It was an emerging technology. I don't think anybody exactly knew how it was going to be used. And I heard about it from as did the rest of the audience, from Dr. Gerald Andreoli, who is our leadoff speaker today. And I'll tell you a little bit about Dr. Andreoli. He is chief of urologic surgery at Barnes Jewish Hospital, the Siteman Cancer Center, and Washington University School of Medicine in St. Louis, Missouri. He received his medical degree from Jefferson Medical College in Philadelphia, trained at the Strong Memorial Hospital and the University of Rochester, and completed his urology residency at Brigham and Women's Hospital and Harvard Medical School. Subsequently, he was a fellow in urological oncology at the National Cancer Institute in Bethesda, Maryland, and then he moved on to WashU. He is chairman of the prostate committee of the National Cancer Institute's prostate, lung, colorectal, and ovarian cancer screening trial, and chairman of the prostate committee for the Society of Urological Oncology Clinical Trials Consortium. At any rate, I turn the platform over to Dr. Andreoli.
Thank you very much. I hope you guys can hear me now. Howard, thanks so much for the introduction. And Mark, I wrote down peaceful vigilance. I like the sounds of that. I think that really portrays what patients on active surveillance for prostate cancer really need. There's a lot of reassurance that we're able to monitor them carefully, and if necessary, intervene before it's too late. So I have a few slides today, and Brian Woodlinger will follow up after my presentation to give you some of the physics behind it. But I think for us lay people, micro-ultrasound refers to a micro-ultrasound or an ultrasound frequency of 29 megahertz. And I will contrast this to the conventional ultrasound systems that are available either alone or in combination with the conventional fusion, MRI fusion platforms. They are only 6 to 9 megahertz. So this results in a 300% improvement in resolution. And I'll show you a few micro-ultrasound images later on. And we are capable of imaging structures within the prostate down to about 70 microns. And the power of this, as we'll get into later on, is that micro-ultrasound is capable of seeing at least as many cancers as MRI can. But unlike the way that we do targeted biopsies as a consequence of an MRI finding, we can do real-time imaging and real-time guidance of those biopsies. So we're much more confident that when we do the biopsy, we are hitting the worst part of the prostate. And I will also add, before flipping the next slide, that you may be familiar with the PIRAD classification for interpreting an MRI of the prostate. And in a very analogous way, Brian and others have come up with a very useful system for micro-ultrasound that is referred to as the Primus risk classification. Again, similar to the PIRAD classification, as we'll show, with 5 different degrees of concern on the basis of the imaging findings. So here is a side-by-side image of a conventional ultrasound on the lower left and a micro-ultrasound on the right. And you can see that there's a lot more detail evident on the micro-ultrasound. And I'll just blow that up a little bit. You can see here the urethra is marked off, coursing right through the prostate. You can see the ejaculatory duct coursing right through the prostate, and it's attached, of course, to the seminal vesicles. This is something that blew my mind the first time I saw this in real time, and that is, these are biopsy tracks of a patient who we were imaging, who previously had had a biopsy of the prostate. And I've never, in the 30 plus years of doing conventional ultrasound, been able to see previous biopsy tracks. And I would put it to you that most of the men who've had a previous biopsy will have evidence of the specific location of those biopsies when we do a micro-ultrasound evaluation of the prostate. Now, I mentioned this before, there's the Primus classification, and the two most prominent features that lead us to want to do a targeted biopsy is the so-called starry sky, which you can see here, and that would be considered a Primus 4 lesion. And a Primus 5 is shown over here, an irregular border with mixed echogenicity within it. That again is very worrisome for cancer, and that would be classified as a Primus 5. This area of the prostate here also has a colorful name referred to as a Swiss cheese pattern, with these are just dilated BPH benign glands within the prostate. But for those of you who might be interested, and you could certainly go to the webpage of ExactView to see blow-ups of the individual imaging characteristics ranging from Primus 1, as we said, Swiss cheese, to the starry sky of a Primus 4 and the mixed echogenicity. But there are other, descriptors like the cauliflower abnormality shown here, smudginess and modeling. And I would say the learning curve, you always worry when there's a new classification system out there that the operator's learning curve might be long, but I don't think that's the case here, because most of us are pretty visual creatures, and we've had a lot of experience with ultrasound over the years, and these pattern recognitions, at least for an experienced urologist and a ultrasonographer, really doesn't take a lot of learning. Where does micro-ultrasound help? And basically, it's in every sort of facet of prostate cancer. Obviously, in the initial diagnosis, definitely in patients who are undergoing active surveillance, and certainly furthermore in patients who've had a treatment and are being interrogated to see if the treatments were successful. Since this is mostly an active surveillance group, one of the hopes a few years ago when MRI became recognized as a imaging system was that, boy, wouldn't it be great if a man could avoid sequential biopsies if he's on active surveillance? Wouldn't it be great if we could rely on just the MRI to determine if a second or third biopsy is necessary? Sadly, over the years, and I don't know if you can see the negative predictive value. So this is, if you are trying to determine if a man's Gleason grade group goes from 1 to 2 during surveillance, and you relied only on your MRI, you would miss about 25% of the men whose cancer had actually gotten worse during that interval. So that negative predictive value is not high enough to rely upon to make a decision that the patient's cancer, in fact, has not changed. But let me just sort of start at the beginning and show you the justification that we've gained over the years with data from micro-ultrasound for us to place so much confidence in it. So here are some sort of headlines from a variety of papers. In the lower left, you can see in comparison to systematic biopsy as guided by conventional ultrasound, the detection rate for cancer increased 12% from 44% up to 56%. And you can see the grade group distribution. You were more likely to identify aggressive cancers in many of the patients if you do these targeted micro-ultrasound biopsies than you would have been if you just relied on systematic biopsies. Here's another head-to-head comparison of micro-ultrasound and MRI, and you can see that there was a very equal detection of the Gleason 7 and above cancers by MRI plus systematic biopsy and micro-ultrasound plus systematic biopsy. In a second study from Canada, we won't hold that against that. Obviously, Laurie Klotz is a great guy and a close friend of mine, but you can see that the sensitivity, the specificity, and the performance characteristics of micro-ultrasound in comparison to MRI look at least similar and potentially even more favorable. And I will put it to you that these were MRIs performed at centers of excellence, and that is where the radiologists have a lot of experience with MRI and the equipment is truly state-of-the-art. I don't want to speak for Canada, but I can tell you in the Midwestern parts of the United States, not every hospital has a 3 Tesla software-enhanced MRI as the equipment to perform a prostate MRI, number one. And number two, the radiologists certainly don't have the experience to interpret the MRI as well as is being done at centers of excellence. And so I think that the micro-ultrasound technology is less expensive, easier to deploy throughout rural areas and urban areas. And it as I said, the learning curve for most urologists is with micro-ultrasound is shorter than the learning curve is for most radiologists in trying to interpret MRIs of the prostate. So we really should keep that in mind as well. Just a few more data series that have allowed us to gain confidence with the micro-ultrasound. Here is how the Primus classification performs. If you have a Primus 3 lesion, you can see the proportion of them that are Gleason worse than 6, meaning 7 through 10. You can see if it's a Primus 4 lesion, what the probability of an aggressive significant cancer is. And you can see the same here for Primus 5. And these are analogous to the probabilities for different PIRADS classification if you were using MRI. This I thought was a fascinating study. And I would just sort of ask you to look at each of these vertical bar graphs. And we want to find the darkest blue cancers because those are the most significant cancers that patients harbor, and we want to be sure whether we classify them. So moving from left to right, if you did just a non-targeted systematic biopsy, which is basically all you can do with conventional ultrasound, you can see the proportion of the aggressive cancers that were discovered. If you move to the right and you did only an MRI targeted biopsy, you found some more, but not all of them. If you did only a micro-ultrasound targeted biopsy, you found more than you found on MRI targeted, but you didn't find them all. If you did a combination of systematic plus MRI targeted, you found more of the cancers. If you did systematic plus micro-ultrasound targeted, you found slightly more than that. But if you want to find the most, you've got to do, and I'll skip over to the last row, both MRI targeted, micro-ultrasound targeted, and systematic biopsies. That puts us in the best probability of finding an aggressive cancer if a man harbors an aggressive cancer. So I just take that to say that no single imaging modality is ever going to be perfect. I think MRI is good. I think that micro-ultrasound is better than MRI. But if you really want to find all of the aggressive cancers, we may need to combine these modalities, for the best overall efficiency. We are continuing to use micro-ultrasound in a variety of different areas over and above the initial diagnosis and active surveillance, and more data are starting to accumulate. Suffice it to say that, one common problem after radical prostatectomy can be a local recurrence in the prostate bed. And with micro-ultrasound, we are able to get such terrific details of the post-radical prostatectomy prostatic fossa that we feel capable of identifying even small local recurrences that might then allow a targeted biopsy to prove that it's a recurrence, and B, targeted radiation therapy using a smaller field than you might otherwise have done. Certainly in the United States, we're doing more focal ablation of small cancers, whether it's with HIFU, cryoablation. There's a variety of different laser modalities out there. But the burden on the physician and the patient is to know how to interpret follow-up imaging after an ablative procedure to determine if it was in fact successful. And we're gaining more and more confidence with the micro-ultrasound as being easier on the patient and more reliable for the urologist to identify the success or failure of a focal ablation. And again, these are some data from Lori Klotz showing that in a relatively small series of recurrent after HIFU ablation of the prostate, 3 of the 12 recurrences, 25% of them, again, were visible only on micro-ultrasound and would have been missed by MRI of the prostate. So this is allowing us to have more confidence if we do choose to use focal ablation as an adjunct to active surveillance, that we're not fundamentally perturbing the imaging characteristics of the prostate, that we're still going to be able to give this patient that sense of peaceful vigilance, that we haven't disturbed the prostate anatomy in such a way that we can no longer have confidence in our follow-up imaging. So in summary, before I turn it over to Brian, I really think that this is a blockbuster improvement in our ability to care for men who are at risk for prostate cancer or who have prostate cancer. So without much further ado, I'm going to go to the next slide. And Howard, are you going to introduce Brian?
Yes, I will. So thank you, Dr. Andreoli. And tell you all a little bit about Brian Woodlinger. He's Vice President of Engineering and Clinical for Exact Imaging in Markham, Ontario, Canada. They're the manufacturers of the Exact View device. Brian has a doctorate in biomedical engineering from Case Western Reserve University, with postdoctoral work at the University of Pittsburgh Medical Center. And he has been working in medical device startups since 2012 with expertise in a wide range of fields, from human-machine interface to ultrasound to bioelectricity and epilepsy. So Brian, it's your turn.
Thanks very much, Howard. And thanks very much, Dr. Andreoli, for doing such a good base for what I'm about to go through. So just to start things off, I want to show you what I think is probably the most exciting ultrasound video that has ever been recorded. This is an injection of stem cells into the fourth ventricle of a mouse. And I think many of you will probably know that preclinical research is extremely important in cancer. It's the way that we develop all the new techniques and medicines that are available for treatment and diagnosis. And so these mouse models are really critical, and it's very difficult to image a mouse. And in this case, we're not just imaging a mouse. This is an injection of stem cells into the fourth ventricle of a fetal mouse in utero. And this was done, the whole thing is about the size of a Tic Tac. And this was done by the company that we spun off from, Visual Sonics, who developed a high frequency micro-ultrasound device for preclinical research. And it's a spin-off. Exact Imaging as a spin-off is really due to the coincidence that the prostate's about the same size as a mouse. And that leads us to the physics here of why these images make such a difference. And it starts off with the frequency. So we're operating at 29 megahertz. Most other systems are 6 to 9, as Dr. Andreoli said. And this is kind of a representation of how much denser that frequency makes our imaging than what you would get with a conventional system. But we don't just image better in frequency, we also image better in terms of the number of crystals in our ultrasound transducer and in how they're packed. And most ultrasound transducers out there have about 128 crystals, and they're spaced kind of at about 100 per inch along one of these curved arrays that gets used. We have 512 crystals in our transducer, and they're spaced 2 or 3 times higher. And instead of being a curved surface, our transducer's flat, which means that the lines stay perfectly parallel as they go deeper into the prostate, whereas the lines of most other transducers diverge, and that makes it difficult to image the deeper structures. This is what the whole system looks like, the micro-ultrasound platform, and it comes with transperineal guides and transrectal guides for those of you that are interested in different types of biopsy. This is the transducer, the 29 megahertz transducer. The business end is over here. And it's about the same size as most other side-firing transducers, but this one tapers at the end, hopefully for a bit of an easier insertion. As I said, we have both the transrectal and transperineal approaches to biopsy. This is a transrectal needle coming in to sample a tiny little hypoechoic nodule over here. And this is a transperineal needle coming in to sample a slightly bigger one here at the apex again. And this is important mostly because transperineal biopsy is gaining a lot of ground in preventing infection, which is one of the major risks, as I think many of you probably know, with prostate biopsy. And so if we can reduce infections by offering this other type of biopsy, we're definitely going to do that. We also have a new approach to fusion biopsy. So MRI is a really great technique for imaging the prostate. It finds a lot of cancer that is missed by conventional ultrasound, but it's very difficult to go from a lesion on an MRI that's taken maybe while you're laying down, probably a day or two before you get your biopsy at least, and then find that same lesion under ultrasound when you're maybe on your side a few days later. And lots of fusion devices are out there that have ways to solve this problem. And our way to solve the problem is that we can see the cancer, let's see the lesion in microultrasound directly. So instead of having a computational kind of approach to figure out where that piece of tissue went, we just try and find it. And we have two ways to make that very easy and accurate for the physicians. One is Fusion View, where we actually build a 3D model of your MRI. And the other is called Cognitive Assist, where instead of building a 3D model of your prostate, we just use the report from the radiologist with the standard 39 PI-RAD zones that they use to describe location. And we just highlight that area in a 3D model for your physician to use to find the cancer. And it seems to work pretty well. We have new data on this now from a study, but mid last year in Paris by François Cornu. And he did this very interesting second look test where everybody got an MRI, and then he tried to find the cancers in microultrasound. And what he found was that most of the time, about 80% of the time, if there was something positive on the MRI, he found it on the ultrasound. And in that case, he found most people had significant cancer. But he also found that in about 10% of the cases, where the MRI said that there was a lesion, said that there was something suspicious, the microultrasound was negative or normal. And in those cases, he did his best to take samples from the whole area. But in fact, none of them came back as significant cancer. None of them came back as Gleason 7 or higher cancer, which is very comforting that we were able to identify some of these false positives on the MRI. And what he also noticed was in these same men, in areas where the MRI was normal, there were some spots where the microultrasound wasn't normal. And he made sure to sample those as well. And in not as many, but in some of those cases, he found significant cancers. And a lot of these were cancers that were extensions of ones that had been found through MRI, or cancers that had moved from the left to the right, for example. And that's very important, I think, increasingly important for things like focal therapy, where we want to make sure we know where all of the important cancers are so that we can plan the right treatment. The second study here is, oddly enough, by another group in Paris at the Institut Mutualiste Montsouris. And they did a head-to-head comparison between sampling MRI targets on microultrasound versus sampling them on another fusion platform, a robotic fusion platform, for example, like the Artemis. And interestingly, they took random samples, systematic samples, as is usually done, and they found about the same amount of cancer in both for the random samples. But in the targeted samples, and these were just MRI targets, we took out all the microultrasound targets, but in just the MRI targets, they found more cancer with microultrasound, which seems to suggest that we were able to find the cancer more accurately than some of these other fusion platforms. And I think if what you're seeing on the screen is the real lesion, the real irregular tissue that needs sampling, that's not very surprising. We've had a really great response from the whole urology community so far. More than 20 peer-reviewed manuscripts in major journals for clinical evidence. We've imaged and biopsied over 30,000 men since we started in 2017, with lots of presentations at major conferences and a few awards along the way as well. And that's led to some great adoption of the technology over just the past few years. We have over 100 customers worldwide. This is a few of them here. And it's growing every day. And one thing I wanted to point out, some people are very nervous about a high frequency technology because they don't know if it's going to be able to see their whole prostate. In ultrasound, if you're familiar with ultrasound, as you increase the frequency, the depth decreases. So for example, the ultrasound that you would use on your abdomen is different than the ultrasound that you would use when looking at, very precise nerve or vascular structure. And so people are often concerned that their prostates are too large for micro-ultrasound. And up until recently, we've been limited to about 80 grams. But we have a new upgrade to the system that is coming out very soon, before the end of the summer, that is going to increase the depth to 6 centimeters and allow prostates even over 200 grams to be imaged very easily. So we're very excited about that. Should be coming out soon. Here's 2 normal prostates and one very large prostate with an anterior cancer up here. Would have been hard to see otherwise. So just to conclude, the 29 megahertz is really the important part of the micro-ultrasound technology. It's a very significant advance, both from the engineering side and from the clinical side. And it's able to provide a very flexible platform for urology with micro-ultrasound only imaging and biopsy without MRI, as well as MRI fusion biopsy. As Dr. Andreoli said, if you want to find absolutely everything, you need to use every technique you have to do it, and a transrectal or a transperineal approach for prostates of all sizes. If you want more information, the website for Exact Imaging is here on the screen, www.exactimaging.com. And we have a physician finder on the website that you can use to find the nearest clinics that have micro-ultrasound available.
Okay. Thanks, Brian. Now we move on to our third panelist, Joe Gallo, who I think a lot of you know. Joe is a retired IT director and is a U.S. Marine Corps veteran. He's on the board of ASPE, and he's also a moderator for ANCAN, US2 support group for active surveillance. Joe has been a true pioneer. He's been leading the way for the rest of us in trying out new technologies, including genomic testing, PMSA, transperineal biopsies, and of course, micro-ultrasound. So Joe's going to share his experience. So Joe, turn it over to you.
Yeah, well, you hit pretty much my background there, Howard. So there's not a whole lot more to go on to it, other than I was originally diagnosed in 2017. And it was by virtue of a systematic biopsy followed by an MRI. A year later, another systematic biopsy and an MRI, both times coming up with three cores of Gleason 6 low volume. So that's what I've been going through with the PSA, and my numbers had been growing a little bit over the past year, to the point where I said I want to, take a deeper look, and the MRIs weren't really indicating anything in particular. Plus, we did have Antonio Westphalen, who is one of the gurus of MRI. He reread my MRIs, and again, found only one small focus that not of major concern. So I got an opportunity to go over to Fox Chase Cancer in Philadelphia, and with Dr. Correa, and we did the micro-ultrasound, which they were one of the early initiators in the U.S. And it sure enough showed up a lesion of concern. We followed that with doing a liquid biomarker just to confirm it, the Select MDX, and it came back and indicated that it looked like my cancer might be progressing. So we then came back in and used the micro-ultrasound to do a targeted transperineal biopsy this time, and sure enough, with that, and we did some other, we did 14 other cores along with it, and I have now progressed to Gleason 8, which it's difficult to say whether or not it's a progression or whether or not it was a discovering an area that wasn't made available before. And as Dr. Andreoli and Brian have just mentioned, I will tell you that my personal opinion is that MRI and micro-ultrasound are complementary. I don't see either one of them totally replacing the other, but working together. And in fact, now that you've heard the presentation about the new focus view, I think that'll indicate it as well. The other aspects, just to close out or to bring up to current, I've had the PSMA PET part of the trial out in California just a little over a week ago with the PYL version. And I think, as Dr. Andreoli pointed out, the effective use of that technology will replace doing bone and CAT scans because they're much more definitive as we go along. And that's my story.
And you're sticking to it, right?
I'm going to stick to it until something else happens. Who knows?
Okay.
But I'm going to keep. I'm sticking. I'm also sticking with the active surveillance groups because it's important that not only do we need to keep educating men and their families and their partners about what is there, what can be done, and as Mark pointed out, trying to get rid of the anxiety side of it by staying informed.
Okay, well, we're going to move into the question and answer part. I'll start off with a bunch of questions, and let's see. And David and Phil will fill in. So are you hearing me okay?
Yes.
Okay, good. Jerry, how long have you been working with micro-ultrasound, and how do you use this with all of your patients? Is it just part of your standard checkup? How does it work in your practice?
Yeah, we have access to this both in our clinic, so we could do biopsies under local in our office, if you would, or we can do procedures in the hospital area where if we're doing an ablation or we're doing a comprehensive transperineal kind of saturation biopsy, we can do it in both venues. And it's interesting to me because I give patients the option. If they need a biopsy, I say, well, I could do it under local in my office versus under sedation, as an outpatient, where, gee, you may have to sit around for a couple hours afterwards and whatnot. It's surprising to me the number of men who just want to do it under local. I don't know why that is, and maybe you guys can tell me. I don't know if I could have a biopsy under local, but it's a large number of these guys in active surveillance will do it.
I'm sorry, Jerry, will do which? They'll do
it under local just to have a shorter, recovery, get back out of the office quicker kind of thing.
Well, I can tell you, as somebody who's had 6 transrectal biopsies and is sworn never to have another, it's individual as far as I can tell. Like my doctors have acted like, oh, well, this is normal, and so, they give me a local. I mean, and I'm sure you remember the days when they didn't even give people locals.
Gruesome.
So, is it just us being tough, strong guys, or just not knowing any better?
Right.
Well, Howard, I've had all my procedures done under local.
Yeah, me too.
Micro-ultrasound, the transperitoneal, transrectals, all
Yeah,
been, all
but
been.
yeah, but you're a Marine and I'm a draft dodger, so
I can't argue with that one.
yeah. So excuse me. All right. You know, do you see the day where these technologies will be merged into one, where MRI and micro-ultrasound are just going to be a single procedure? Brian?
I think we're already there with Fusion on the platform.
But you're not a manufacturer of MRI, right?
No, we very specialized on this high frequency ultrasound.
You mean, could you do an in-bore exact view, I guess? Is that what
Yeah.
you're saying? Some
Oh.
robot driven in-bore exact view MRI thing?
Yeah, that's the dream, right?
That's going to be tough. Ultrasound crystals usually don't like MRI magnets.
Oh, okay. And you know, when I first heard about this technology, you know, was, you know, just 3-4 years ago. I mean, was the original vision that the micro-ultrasound might take the place of the MRI, or has it always been thought that they would be complementary?
You know, from the company point of view of what we were going for, I think it's a little bit of both. We think that we can reduce the amount of MRI that's needed, for sure, but there's always going to be value in that other image, you know, whether it's for everybody or for some group. So I don't think we ever intended to eliminate it entirely.
Yeah, Jerry, let me ask you this. I've been hearing more about this. I don't know if in reality more is going on, but I've heard this from urologists in Australia, urologists in England, where they are monitoring active surveillance patients with MRI alone. In other words, displacing biopsies. Is this the future, or do you think, you know, based on the statistics that you showed us, do you think this is a mistake?
I'm very nervous. You know, MRI misses, depending on the center, and these are the centers that have reported their data, as few as 5% or as many as 20% of the clinically significant cancers that are in the prostate. And I just worry maybe those societies aren't as litigious as the United States. I mean, to delay the diagnosis of the significant component of a guy's cancer, that could put him at risk. And I just don't have that much confidence. And as I said, if patients are being seen in centers that don't have a large amount of experience, the data are going to be even worse in terms of the miss rate.
But I mean, have you heard much about this? Where I think it's Dr. Moore, Carolyn Moore.
Yeah, Carolyn, I was just going to say, University Hospital London will do that. She's an expert, and British men are very stoic and you know, just put up with things. But I don't think that anybody in the United States, I don't think there's a radiologist. I don't think Jelly Barents from the Netherlands, who's sort of the father of MRI, would take that view, to be honest with you.
Okay, so Phil and David, do you have some contributions now?
I've got a few questions that I've written down. Would micro-ultrasound be useful for someone who can't have an MRI due to a metallic hip replacement?
Absolutely. That's a real pacemakers, other things along those lines, definitely.
Great. This one is interesting. From this person's a male breast cancer survivor of 9 years, BRCA2 positive, and with BPH. Would like to know if micro-ultrasound would be useful for this person's surveillance.
I would think so. Absolutely. He's at increased risk for a significant prostate cancer, and irrespective of his PSA, that's the one thing we've learned. You can't just rely on PSA as a criterion to look for prostate cancer in all men. So he should have some imaging modality, in my view.
Great, thank you. What about micro-ultrasound in identifying spread in people with advanced prostate cancer?
For local staging, Brian, I don't have those data at the tip of my tongue right now. I assume it can help.
Yeah, we just got something out on local staging for basically knowing whether the cancer has already escaped the prostate through the seminal vesicle or into the space around the prostate. And it looks quite promising. The accuracy in this one single center study from Italy was higher than the accuracy for MRI at predicting local staging. But in the advanced prostate cancer, you also have to worry about more distant metastasis. And for that, I'm sure Dr. Andreoli would recommend PSMA.
Thank you. This one's for you, Brian. There's been some talk about cost versus MRI, cost of your product versus MRI. Perhaps you could elaborate on why one other person talked about. He said it appears this tool is only used by a single private urology practice. Why hasn't it been adopted in major hospital health organizations? So, floor is yours.
Right, and that's my fault that our physician finder is not fully up to date yet. We're still adding all the new groups that have come on board in the past year. It's one of the problems with growing quickly, as I'm sure you can imagine. So in California now, instead of just one private provider in LA, we also have UCSD, UCI, UCSF, and Genesis Urology on board, just in the past little while, to give you an idea of how that density of providers is changing right now. But in terms of cost, so there's no comparison in cost with an MRI. An MRI magnet, costs several $1 million alone, just in terms of the capital cost, the equipment, and an MRI scan will run you, somewhere between 2 and 10 times the cost of a micro-ultrasound scan, depending on where you are.
And you're talking about the device, or what about the actual cost for
the actual scan? The actual scan is about 2 to 10 times the cost of an MRI scan.
So what is, what roughly, I know that there'd be a difference from place to place, but what is the range of cost, for one of your scans? And
no, not a scan, the machine itself.
Oh, I'm talking about this. I'm talking about the cost for the procedure.
So I'll answer both questions. The cost of the procedure is actually right now reimbursed under existing ultrasound codes. So the same way a physician would bill a regular biopsy or a fusion biopsy or a regular ultrasound imaging session, they would bill a micro-ultrasound the same way at the moment.
You're talking about the United States. What is the
United States and in Canada?
What is the experience in Europe?
Europe is very different. It varies by country. In some places, particularly in Germany and in some ways France, there's a lot of private pay for some of these services. So I won't pretend to understand all of those healthcare systems, but at least in the United States and Canada, where I'm more familiar, we're covered under existing ultrasound codes. And there are some places that ask for a bit of a surcharge, but it's fairly small, just for the extra time to read the image.
And Jerry, in terms of transperineal, there's more than one approach to this. What do you use?
Well, we previously used a conventional B&K Bruin Care ultrasound with the precision point if there wasn't a target. If there is a target, I do transperineal exact view. And now I'm moving to exact view even when there is no target, because I think, you know, as we said, the imaging of the prostate is better than it would be with a conventional, you know, sagittal probe from B&K kind of ultrasound.
Well, the one with exact view, can it be done done in the office, or is it only in the operating room?
I do it only in the operating room because I just think it's really painful to have a transperineal biopsy. But again, you guys tell me, I wouldn't like the sounds of that for my biopsy.
Actually, we should ask both Joe and Mark, who both had both varieties of, well, they've had transrectal and transperineal, but maybe they can address the pain factor. We know Joe's a stoic, but we don't know about Mark.
Well, Joe's a Marine, if you, and I'm a draft dodger too. So,
Howard, I've had the transperineal, and I didn't find there was any difference in terms of pain either approach.
Well, then, so if I could chime in too to respond to Howard. So I decided 15 years ago not to have any more biopsies because I was concerned about sepsis. So I had one many years ago. So there is I don't have any recall about the pain factor there, but I don't recall that there was anything that uncomfortable. But with regard to the micro-ultrasound, and I said this to Brian before, that there was a little bit of discomfort with the micro-ultrasound, but it was absolutely fine just doing it in the office. It should be done in the office. I haven't had a transperineal biopsy because I chose, well, I just learned with ASPI, actually, with this organization, I just learned about the transperineal. I wasn't aware that was really an option for me, but I'm not, because of my situation now, I'm not planning to have any more biopsies at all.
Well, for my transperineal, I can tell you that the real discomfort was getting the anesthetic injection before I actually had the biopsy done, and it's done in a different position. You're up in stirrups, other than as compared to what you would for the transrectal. So it's a little bit less comfortable from positioning, but I'll let Howard not make any more comment.
I think some men aren't limber enough to get into that. We call it the lithotomy position, where you're on your back with your legs up and spread. It's challenging for some, especially if they have arthritis and whatnot.
Well, Joe, all those years of yoga paid off, right?
I'm about ready to start. Yeah.
But Jerry, well, you know, Phil ought to chime in on this since he's had both too. So you feel like it's.
Yeah, I guess I'm limber enough to be able to get into that position, but I honestly found it more comfortable than the transrectal. I just I could hear the clicks a lot less, I guess, but it just seemed to be a more comfortable procedure. The transrectal, just every time there was a click, it was just a lot less clicky on the transperineal.
Well, maybe you're missing out on the echoes.
I didn't want the echoes.
Let me just refer those of you who are on this call now and did not see our transperineal webinar. Go to our website. Really outstanding webinar on that. And with the transperineal, they're not using antibiotics now, generally not using antibiotics. So do visit the website to check that out.
Well, and we're going to have another program on it last Saturday in August. So something else to look out for. But Jerry,
Hello?
yeah,
Howard, I just wanted to chime in on the
Yeah.
transperineal because I had my transperineal actually inside an MRI tube. So I was at Brigham, and it's called an in-bore transperineal biopsy. So I was basically in the tube, and I think, I don't remember, but maybe slightly, I was slightly elevated towards the, end where he needed to work. But that was different, being in a tube.
So this is Richard Zabo. In the literature review I did, pooled averages for visual analog score for transperineal came to about 3.17 over was about I think 4,000 cases or so. And when I averaged the pain scores for transrectal from another review over, I think it was 10 other studies, that was 2.5 was a visual analog pain score. So it's pretty close. Comparable.
Richard, let me ask you a question. Richard's is a researcher who's written a lot about transrectal versus transperineal. Have you looked at the exact view transperineal?
I'm very interested in it. Yeah.
Okay, but you don't have any comparison on pain or anything else.
I can't see how it'd be very different. I mean, it's just, you're still having to go through the same anatomic structures with the anesthetic needle and with the biopsy needle.
We can talk afterwards, Richard, one researcher to another. There's a few things about the way the local anesthesia is done that can cause changes in those pain scores, and we can see if we can break down that data and maybe figure out how they correspond.
Yeah, I'm interested, Jerry. I mean, part of the pitch for transperineal is to get away from, sepsis. It seems very convincing that you can avoid sepsis by going transperineal. So I'm wondering why you would continue with transrectal. And I'm also wondering, since you give your patients a choice, what's the most popular one on the hit parade?
Yeah, most men will choose to have it under sedation, and then if that's the case, I do it transperineally. If they want to do it under local and the lesion is posterior, closer to the rectal surface, et cetera, then I would do it transrectal in the office. But if they had an anterior lesion, I would always steer them to a transperineal. But under sedation, maybe I'm not patient enough to infiltrate the medicine, wait long enough, and reassure the patient enough such that he's not moving. Because I'm paranoid about patient movement. Squeezing of the buttocks changes the shape and configuration of the prostate. I hate to put a guy through everything, to do this and have some artifact of unperceived movement cause my targeting to be less than ideal.
Well, certainly, can I answer that? Certainly, it's easier to do it under sedation, of course, but it's just not. It's not economically feasible for our whole health system to go that way. But also, there's better remuneration to. In a way, you can recoup. I mean, your fee is less, is my understanding, but there's better remuneration if you do it with sedation, at least to the surgery center you're working in. But there are all other alternatives using nitrous oxide laughing gas and pre-treatment with some Percocet, things like that. If you really want to decrease the movement, but it's the real problem is remuneration, I think, in this country. Otherwise, I think transperineal would be universally adopted pretty easily because of the better yield of clinically significant cancer when you're doing targeting, when you're doing MRI targeting.
That's why I was just
And
gonna
of
ask,
course, because you can get no sepsis.
doesn't the transperineal also provide more access or access to more of the prostate? Okay, so that in itself, is a significant factor.
Well, I mean,
No, I agree with that.
yeah, the reason of course, the reason it probably has the reason it has a higher clinical yield of clinically significant prostate cancer might have to do with the configuration of the tissue at risk, which is cylindrical, the peripheral zone. And when you're going, the trajectory of the biopsy needle takes only peripheral zone. You're not getting half transitional and half peripheral when you're coming up from the rectum. But, obviously, if you have a big target transrectally, it's simple to just go transrectally, but then you're exposing that patient to sepsis, which is a serious problem in the United States. And Mr. Walensky has, written a whole article on the actual death rate from this, which is not well reported.
Well, let's see if we can finish answering some of the questions in the chat box. Somebody asked, where is the micro-ultrasound available? Brian, maybe you had your map up there. I don't know whether you want to put
Well, he had a link too.
Yeah, I'd direct everybody to the online physician finder.
Okay, did you put that in the chat box?
I will put it in the chat box right now. It's not perfectly up to date. We're updating it every day as new groups come online, but it'll give you a good idea of where the closest center is to you. Let me cut and paste that in now.
Somebody asked about the most urologists don't do a transperineal yet. Again, I encourage you to go to our last webinar because there's a lot of information. And Dr. Szabo, thank you for joining us today because he was part of that webinar last month. So probably some of those answers about the transperineal could be found in that last webinar.
Well, I do think the more that we learn about that there are issues, and there is very low penetration, I think, in the United States, no pun intended. But maybe we should steer back to the topic of the day, which is micro-ultrasound. And Brian, is the device mainly marketed to urologists, or do you also market to radiologists? And which specialty mainly has it?
And radiologists, yeah, both urologists and radiologists. In the United States, most prostate biopsy procedures are done by urologists. So in the United States, it's predominantly urologists that have the system. In Canada, it's a little bit more mixed. Here in Ontario, we have both urologists and radiologists using the system. In Europe, also, it's fairly mixed, both radiologists and urologists using it, depending on the country.
So are there turf battles over this?
I don't know about that. I think in each country, in each healthcare system, there's a particular specialty that it normally does prostate biopsy and prostate analysis, and I don't think there's a lot of fighting in each area.
Well, you're probably putting a spin on that, Brian, because these guys love to fight.
Everybody loves to fight. We have to try to be diplomatic and give everybody benefit.
You're sort of the Switzerland. You are an arms dealer. You'll sell to both sides.
I have to say, when we first started and we developed Primus, to give you an idea of kind of the balance on our boards, we had one radiologist in the group and 4 urologists. And I think that's probably about the ratio that has come along, but this is an image interpretation system. And so the radiologists are usually very eager to see what they can see. And at the same time, most of the urologists, particularly in the US, are fellowship trained in ultrasound. And same in Germany, they're very good sonographers. And so the urologists pick it up very naturally as well.
I have another marketing question for you. Is the market the private practitioner or is it the hospital?
Well, it's both, depending on the group. So certainly the large research hospitals have been very quick to adopt because it's new and exciting, I think, and they want to be on the cutting edge. But a lot of the private clinics, maybe not single urologist clinics, but a lot of the large group practices that are very common around the United States, they understand the benefit as well.
Let's see if we can get back so we respond to some of the things that are in the chat room. And Phil, chime in here. I'm just trying to keep this focused on the chat room, but I see here one on would the urine biopsy, such as the imminent Sentinel or MIR scientific, be appropriate to wait for this year to be followed by a micro-ultrasound? Dr. Andreoli, do you have a thought about where the MIR would fit in this process of monitoring?
Yeah, well, for a man on active surveillance or for a new diagnosis?
Let's treat with
Both.
Yeah, both. Yeah.
Yeah. So if I can get an MRI for a patient who first presents with an elevated PSA, for example, I get it. And then I would plan to act one way or another. I believe the guy's going to end up with a biopsy. He'll have an exact view biopsy, whether it's fusion, depends upon whether there was an MRI lesion or not.
Let me catch up with the question here. He's speaking about the urine approach, the imminent.
Yeah, he's talking about
Sentinel and MIR scientific urine approach, and how that would fit into the monitoring process.
It's going to be increasingly available starting in September. Dr. Klotz is the medical director of the company that's producing it. The company's based in New York City.
Yeah.
I'm not familiar enough to say about that, to be honest with you.
No worries. That's fine. Okay.
We'll just have to do a program on that. So
it's a very interesting test, a very different approach. I've spoken to Laurie Klotz about it previously, so he's very interested in it.
He likes yours too, so don't.
So after the prostatectomy, biochemical recurrence, which one is better to use? Micro-ultrasound, PSMA, PET scan in locating very small tumors with low PSA?
Yeah, I think most people would answer that with PSMA. Okay. But the other truth of the matter is the Axumin scan, the FACBC scan, which is already available in the United States. It's sort of like the MRI and exact view. They can be complementary because there are some tumors that don't express PSMA, but because of their heightened metabolism can be identified with an Axumin PET scan for biochemical recurrence.
Maybe you could give just a brief explanation of PSMA, because I suspect a lot of the people don't know what that is.
Prostate-specific membrane antigen. So it doesn't circulate into the blood as prostate-specific antigen does. And most prostate cancers, until they become very dedifferentiated or a neuroendocrine differentiation or something akin to that, will express that. And it actually also tends to get upregulated in patients who have androgen-independent tumors. So many prostate cancers can be imaged with a PSMA targeted agent like PYL or gallium. There's probably a half dozen of them out there right now, but not all of them. And so there are some comparative studies looking at PSMA versus what we used to call FACBC PET scan, marketed in the United States as Axumin, which until last Friday was the only scan you could get for men with biochemical recurrence. Actually, they're a little bit complementary. Neither scan finds all of the sites of recurrence.
You know, what role does this technology have for people with low risk or people on active surveillance?
Well, you know, the imaging within the prostate from these PET scans is not precise enough, really. They're not in the same order of magnitude as MRI or exact view, by and large. That's not to say that will always be the case, but for right now, there's too many false positives and false negatives.
Phil and Mark, are you still monitoring the chat?
Yeah.
We are. I'm not sure that they're.
Go ahead, Phil.
Yeah, I'm not sure that there's really been.
All right. Well, here's one while you're thinking about it.
I think we have.
Here's one. So with micro-ultrasound costing so much less than MRI, are the major insurance companies covering them?
Okay.
We said they were covering them, but what strikes me is why aren't the insurance companies tripping over one another to get these? This is maybe for Brian. To get these things installed. I would think they'd be knocking on your door.
You know, from their point of view, certainly there's a bit of a tidal wave of MRI and a lot of cost there that they probably are worried about. Let's give them, you know, a little bit of time to get up to speed. These things take a long time to get through the insurance companies.
Okay. Phil, any other questions you think we should answer now?
I think we answered no. No, I haven't really. Well, you know, there was one way back, which let me see if I can find it. I'll read it because I'm not sure I understand it. Would micro-ultrasound be a potential alternative to either BPH or MRI for assessment of prostate cancer? He's interested in getting a prostate artery embolization to ameliorate urinary retention events, but the IRs seem to require an assessment of prostate cancer prior to the procedure. So he'd like to know how well is micro-ultrasound recognized within the urology and or interventional radiology communities. Well, I think Brian's talked to that, but if anybody wants to comment on that.
Yeah, I mean, it would fit in, especially, you know, now that you can image larger prostates. By and large, prostate artery embolization is for the largest prostates out there as an alternative to doing a invasive procedure to enucleate the prostate or something along those lines. So yeah, and it's a smart strategy to make sure that you've ruled out the presence of significant prostate cancer before embolizing the prostate, because you wouldn't know what you were looking for later and how you've perturbed, you know, your ability to find prostate cancer later on.
Thanks very much, Dr. Andreoli.
You know, I did see a couple of times this question about precision point. Precision point is not an imaging modality. It's just a device that allows you to put a biopsy needle through the perineum into the prostate. So, and Brian, correct me if I'm wrong, you can use precision point with the exact view.
Yeah, you can. I think our transperineal adapter is easier, but
I do too. But I was talking to somebody that said that you could use, they use a precision point attachment onto the exact view ultrasound.
Yeah, for sure. It's you can use it with just about any side fire ultrasound type probe. Yeah.
Is your probe like theirs disposable?
The biopsy guide's disposable. The probe's reusable. Yeah, so the probe gets high level disinfected, fully cleaned between procedures. It's in a sheath as well that covers it. And there's a sterile attachment that the biopsy needle goes through, which gets thrown away between cases.
I had another question for you too, Brian, in terms of, where the technology is heading. I think maybe you or someone else had mentioned to me that Doppler ultrasound is coming, and a lot of us don't know what that is and how does that fit in, and what else is in your pipeline?
So the interesting thing about micro-ultrasound right now is it's what's called anatomical imaging. All we're imaging is kind of the structures of the body. We're not imaging any of the function of those structures. And that's a real contrast from MRI, because MRI, multiparametric MRI, has 3 different modes, which look at the anatomical, the T2, and the diffusion, but also they use a contrast mode to look at how much blood flow there is in the area, and that the amount of blood flow increases in areas where there is cancer, tends to increase. So the fact that we're doing as well as we are compared to MRI without any functional imaging, I think is really surprising. And I'm really excited about the idea of multiparametric ultrasound and adding in some of these functional modes to micro-ultrasound to make it even better. And one of the ways to do that is called Doppler ultrasound or color flow ultrasound. And it's a fairly old technique now. It's never been shown to do a really great job at finding prostate cancer, although it can be useful in some cases. But there's a lot of new stuff, things like elastography, things like contrast enhanced ultrasound are showing much better results. Contrast enhanced ultrasound in particular, I think, has been really good. Not available in the United States, but these are the things that we're kind of watching for further improvements on the system.
So we are getting pretty far along on this, and you've all been very patient, particularly Brian and Jerry. If I could Jeff just got on the phone. Jeff, do you want to speak for just a minute, and then I'll close this out?
Hi, everybody. I'm Jeff McLennan from Rockland, California. They pulled me out of the barn to be their fundraiser, so I hope you understand. If I'm a bit of an animal going at this, that's why they hired me. First of all, hired isn't the appropriate word. We're all volunteers here. Most of the guys already in leadership positions are giving out of their own pockets. So I'm here to show you this little envelope. It has a little dollar sign on it. And I want to talk to you a few points real quickly. Number one, Amazon Smile. If you go to our website, you can donate through that modality. Another one that I'm highly in favor of, and I just signed up, is called monthly giving. Again, if you hit the donor button on our website or contact me or any one of us, I'd be happy. I mean, whether you give $5, $10, $20, or $50 a month, it's really important, because as you can see by today's quality and effectiveness of this program, we really work hard. And just imagine what we could do if we had a few bucks in the bank. So I'm pushing that. We also are interested in any bequests and any things to do with leaving money based on your death. So again, please contact any of us for that. And I'm just looking in the envelope here, and I've got a little funny card in here, and I wonder who sent this. It says IOU on it. So with that, I want to encourage all of you to give a few bucks and watch us grow, and I bet you we'll all be healthy for it. Thank you very much.
Boy, it felt like suddenly we were on public television.
Well, I'm out of the barn.
That was well done, Jeff. Thank you for that. But I particularly want to thank Dr. Andreoli. You know, your manner just exudes peaceful vigilance, and I would love to be your patient. You've got such a great manner about you. Brian, your knowledge of this area is outstanding. So we really appreciate your time and Dr. Andreoli's time. Everybody's volunteering their time here together.
Hey, don't forget to thank Joe.
Well, I take Joe for granted. Thank you, Joe. And we hope to see you the fourth Saturday of June. We'll be talking about, we'll be talking about anxiety and psychiatric issues around this at that time. And so if any of you are inspired, please get in touch with us and volunteer. We need all the help we can get. So any closing words, Howard, from you, or are we?
Yeah, just thanks for the generosity of our panel and everybody that showed up. And we're thinking about those who didn't. They can watch the video.
Yeah. And thank you, Howard, for making this connection. So, by the way, if the program team could just stay on for about 2 or 3 minutes, and it's up to you, Jerry and Brian, whether you stay on. But
yeah, you can listen to Mark chastise us.
Well, listen, guys, thanks for the opportunity. Happy to participate. Very grateful that there's an organization like this helping men navigate this sometimes complicated, confusing, and emotionally challenging circumstance. So,
and Jerry, if you ever are facing down the choice of a biopsy, be brave. It isn't that bad.
Okay, I will keep that in mind. All right.
Thank you, everyone. This has been really great opportunity.
Thanks, Brian.
Thanks, Brian. Take care.